the general access plan in terms of delivering care and access is out from the government. It came out a couple of days ago, and myself and Andy have been having a good look at this document to help explain what this means for both you as a practice, as a network, and also your patients. And does it actually help to achieve this? We're going to find out as we review the whole document and stuff. So let's crack on and take in hand to primary care and learning. Hey GP learners, and welcome to this episode where we're reviewing the delivery plan for general practice access that's been released by the government and NHS England. It's a whomper of a document, 46 pages in total, and there is so much to cover. So don't worry, we've got you covered. We've had a look at it, and we're going to go through all the different stuff it mentions. And there is absolutely loads in this document, isn't there, Andy?
Yeah, it's a really interesting document, actually. So came accompanied by another one of those letters from NHS England, just indicated that the intended audience for this document is actually individual GP practices. A lot of the documents we review are sometimes for ICB or PCN audiences. This is, yes, for all of the above and individual GP practices. And at this time, Gandhi, this is a plan document, isn't it? So we've reviewed contract changes before. We've reviewed sort of select committee reports, and this is a plan. So I guess what I'm taking from that is this is an indication of what the Department of Health think should happen, think is a good idea, but the actual instruments for delivery are the changes that they make to our contracting models and some of the other things. And this is more of a, this is what we want, this is the direction that we will be driving in document, or at least that's how I've received it. Are you taking it in the same spirit, Gandhi?
Very much so. And there is actually a load of stuff in this. So first of all, like I said, don't worry. We will be putting timestamps and stuff after we finish the episode. So do, if you're watching this on the replay, if you want to watch this back again later, check down below in the description of the video and stuff, because you'll get timestamps for various sections, because there's a lot here. And you probably will want to go back and watch some of this because of the amount of detail that we're going to have to go into to cover this document and do its justice and stuff. But we're going to crack on with the summary, which is a good place to start, isn't it, Andy?
Yeah, I mean, first of all, let's just skim through the contents, because that will get people orientated in terms of what to expect from this episode. If you're watching live, sorry, no timestamps, it's live. But if you're watching a recorded episode, then we'll timestamp the little bit so you can jump around. And as always, grab yourself another copy of the document. Consider this an introduction. We've got the wrong screen up there.
Wrong screen share there, Andy. Yeah.
Let me just go into the screen share settings again, and let's make sure it's playing up a little bit this morning. Share window, delivery plan. Okay, there we go. So we've got the right thing. So yeah, always recommend grabbing a PDF of the document yourself so that you can have a look and consider this your guided tour, and you can refer to things in more detail later if you're putting things into action. So just looking what's in the documents, we'll spend a little bit of time just looking at the summary and the context of the document, and then it's split into actually a fairly small number of sections. So we will go through all of the sections, spending particular time on the ones we've highlighted here. So we'll spend a bit of time on the summary. We will look at the measures to empower patients, because it's actually quite an interesting section. There's a section on implementing something that they are calling modern general practice access, which is a new term introduced by this document, as far as I can tell. So we'll be having a look at what they mean by that, and building capacity. So about building capacity to deliver this, cutting bureaucracy. Interesting section. We might signpost out to some other resources there, and then they talk about how they're going to deliver the plan, and then they talk about engaging on the future of primary care. So there's a little bit of discussion about reviewing the general practice contract and reviewing the PCN DES, and that's happening at the same time, I think is interesting. We'll probably talk a little bit more about that when we get there. So that's the plan, Gandhi. You happy with how we're proceeding this morning?
Definitely. And I think the first place to start, so actually there is a nice one-page summary in terms of some of the stuff to look at. As ever, the devil is in the detail. So we're going to go into that a bit later on. But this summary is a nice place to start, isn't it, Andy?
It is. I was going to give some context. The screen sharing isn't showing other things. What I was going to do was just highlight that this section is really talking about tackling the 8 a.m. rush, and it kind of picks out the bits of the document that are designed to tackle this. And I was going to show Rishi Sunak's Twitter thread for the last week, because it is full of statements lifted from this document about improving access to pharmacy for contraceptive pill, blood pressure management, tackling the 8 a.m. rush comes up a few times. So it's just interesting that this is quite a political talking point, has been used as such over the last.
Mm-hmm.
This is almost a crib sheet for somebody who wants to talk about how this document supports the objective of eliminating the 9 a.m. rush at the GP surgery. So it's just one page and it lifts those things out. So what are they looking at doing? So empowering patients by rolling out some tools to look after their own health, which is great. There's some emphasis on expanding use of the NHS app. The obligation that ICBs have already been given, or the guidance to expand self-referral pathways. It's talking about, and it does talk about in more detail in the document, about expanding clinical community pharmacy roles to issuing contraceptive pills and blood pressure management. And it talks about the launch of the Pharmacy First scheme. Again, I'll talk about this a bit more when we get there, because something called Pharmacy First has just been decommissioned in Nottingham. So this is interesting to know that it's coming back by the end of the year, perhaps a slightly different form. So that's that. It's implementing modern general practice. So this, as far as I can tell, this talks about the change in the statutory, those changes made to the core contract by the deployment of the statutory instrument that comes into place on Monday morning, the 15th May. We've done another video all about that, which I'm sure we'll link somewhere. But that talks about the move to digital telephony. That was within the statutory instrument. Providing practice with digital tools and care navigation training. That's something additional. But really the thrust of this is about changes to how patients can contact their GPs and what appropriate response they will expect to get, which cannot now be call again tomorrow morning or call at lunchtime when new appointments are available. It has to be one of a defined number of responses, which do allow quite a lot of flexibility for practices, but they don't include call back at another date. Talks about building capacity. So here they talk about funding. We'll go into that in a bit more detail, because a lot of this funding is recycled funding that's being re-announced, which we often see and have seen from government. So over the years of all ilks. Then they do talk about actually expanding GP training and some of the options training for GPs, both UK graduates and people with overseas sort of nationality and statuses. Changes to the pension fund to encourage GPs to stay within the profession and work longer, and other measures to bring GPs back into practice who have retired. And then there's something about changing planning guidance. There's something around the planning of new GP surgeries in there, which we might talk about if we have time when we get there. And then
there's actually some interesting stuff in there, and particularly in areas where there's high growth of patients. I think that's a section you're definitely going to want to check out, because there are some definite actions in there that I can suggest that you may want to consider in the near future.
Yeah, hopefully we do get time. We'll make time, Gandhi, to talk about that when we get there. And then finally, cutting bureaucracy. So they're talking about is streamlining the interface between primary and secondary care. Often frustrating, isn't it? Navigating that interface either on the day on telephones or how we communicate via referrals and writing. So that's good. And then also referring back to the bureaucracy busting concordat, which is a very Johnson-esque title for a document, I think. As a certain amount of journalistic flair there. But that talks about how other areas of government can reduce the burden on general practice by how and what requests for information they make to support their functions. So things from DVLA or from things to do with aviation, things like that. And we'll look a little bit at that, but we did another video on that as well. And then they talk about streamlining the investment and impact funds, something they have already done, reducing the number of indicators from 36 to 5 and recycling the rest of the money to support the access work that is being done. So that's that. Any reaction to that? That was a really quick run through of some of the highlights of the documents, which we'll expand on later.
Yep. So I think there's a lot in there, like we've mentioned, and some of it is really interesting. There's a lot of rewords throughout this document, but interestingly, the one they've focused on is retargeting. Seems to come up a lot rather than repurpose or recycle or renew or all the other RE words and stuff. But retargeting seems to come up quite a lot, and we'll cover that when we get to the modern general practice stuff and things like that. But I think probably best just to go through the rest of the summary quickly, and then we can obviously have a look at it from there.
Yeah, absolutely. So summary pot, we've not highlighted too many things in the summary, really. It contains what we've referred to in the past as the usual platitudes to general practice. They recognise how difficult it is. They recognise the pressure they're under. They recognise how many more new appointments and additional activity that general practice is doing. This never seems to make it into the mainstream media, funnily enough, but there's always a section in the documents that no one picks up and does an article in the Daily Mail about. But there is some gratitude there. They're also acknowledging that, you wanted to just highlight this, Gandhi, because you've done some maths around this observation, but they're talking about the increased demand and pressures on general practice. So talk about this highlight a bit, Gandhi.
Yeah, I think so. So one of the key points it mentions here is that the number of patients in England aged 70 or over is up a third. So it's gone from 6.1 million to 8.1 million. So that's 2 million additional in that age category. And this group consults on average 5 times more than a younger person. Okay, so even if you take that as one consultation for a young person per year, which we know is actually, it's much higher than that. The average patient consults about 3 to 4 times, and I think that's gone up to 5 to 6 in the past few years. And actually, general practice funding is based on only 3 to 4 contacts per year. Important to remember that point. But okay, so if you take that as, minimum one patient from the younger age groups, that means if you times that by 5, that's 5 contacts. You're talking 10 million additional appointments just from that age group alone that has already happened. And the reason why that 10 million is a really useful number to remember, and I want you to remember this when we get to the pharmacy provision scheme that's going to come up and stuff. So 10 million, remember that number, and you'll see why this is really important in a second.
Yes. So they talk about, pandemic changing the landscape. There are a number of references to other documents within this document, and the fuller stock take probably has the most references. We've done a video on the fuller stock take. I'm sure we'll link to it in the show notes. But there's a lot of talk within the fuller stock take about streamlining care and the multidisciplinary team and how PCNs can be more effective. I will signpost you back to that document. But they say, before we can fully implement any rider reforms, we need to take the pressure off general practice and tackle the 8 a.m. rush. So they're just affirming that that's one of the big pushes of this document.
And I love the sentence after that as well. Although this plan supports all 3 elements of the full stock take vision, it makes no excuses for focusing on the first. And I wonder why, because it's the first that is a voter's prerogative, isn't it? It's about tackling the concept of what affects the voters more directly, rather than the other stuff, actually, which potentially will have more impact on healthcare provision and service. But as ever, it's access that seems to be the focus of the government, because that's, to be honest, the thing that gets them votes.
Yeah, and we've talked in the statutory instrument episode about the effect of the ATM rush, but actually it's not really, well, it's yet to be seen whether it will take the pressure off general practice, but I think it's so far created a lot of fear within general practice about actually increasing workload and increasing friction with patients, and a lot of fear that other services may be overwhelmed as well by basically mandating that GP surgeries have to tell someone to go somewhere else within the system if they cannot deal with them themselves, and that might have quite deleterious effects on the system. And this plan has 2 ambitions: tackle the 8 a.m. rush, and for patients to know on the day how their contact and request will be managed. Do we want to talk a bit about that contract change, Gandhi, or we've done that a lot of service?
We've kind of covered that in previous episodes, Andy, like you said. And I think if people want more detail as to that particular aspect, do feel free to look back at our previous contents, because we've gone into that in detail, both with the GPC episode, but also our individual episodes and the ones that we've done with Ben and Tara as well, that talk a bit more about that aspect and things from the PCM Plus side of things. So we've got content, and we will direct you to that towards the end and stuff. But feel free to have a look at the specifics around how you can manage some of that later, because there is some other stuff we need to have a look at and things.
So people will notice I'm just scrolling, because I think at the end of the summary there is discussion. So first of all, before we move into the main document, they're just highlighting the main sections, and in fact these are the ones that we are going to focus on as we go through the document. that this document focuses on: empowering patients,
Mhm.
implementing modern general practice access, this new term, building capacity and cutting bureaucracy. It then just talks about the funding that's been made available. So I think some of the keywords here is retargeted. So NHS England and the Department of Health and Social Care have retargeted over £1 billion committed to. So I guess that's money that was targeted at other things and now it's not new money, essentially, is what that means. And we just tried to identify where we thought some of these came from. So 240 million of funding for new technologies and support offers to primary care networks. I guess a lot of this will be telephony.
Mhm.
Did you get a sense of where this is retargeted from, Gandhi?
No, and that's one
Oh,
of the harder things to figure out. When they talk about retargeting funds, it's really unclear as to where these particular funds have actually already been retargeted from. So what services have they taken these away from in order to provide that funding? I suspect it's to do with things like IT refreshes, the IT budgets for general practice as a whole. There is some suggestion this will also incorporate the online consultation funding. So those were additional pots that have been given in the past few years because they weren't actually accounted for in the actual GP contract. And there is a commitment to provide the online consultation tools to general practice from this summer onwards, and that's later down in the document. So I think that's where some of those funds have come from, as well as providing additional funding for supporting the cloud-based telephony. But it's very clear it's not new additional funding. They've taken this from somewhere else in the system.
yeah, and I think a lot of it is sort of just recommitted funding as well, because a lot of it feels like it is for the same thing. They're just
Yeah.
restating that within the document and incorporating it in a sort of a big headline figure like 1 billion. So it's 645 million to expand community pharmacy services. So this is the one where I wasn't clear where I definitely wasn't clear where this had come from.
No.
And in my notes, I just sort of highlighted they talk about community pharmacy first scheme, and it's just
Mhm.
interesting that something of the same name was recently decommissioned. And we also have the community pharmacy referral scheme that has been announced for some time, and I do wonder if some of if that's the funding that we're looking at here
Yeah.
potentially. They're not claiming it's new; they're saying it's retargeted. Redirect the 246 million of the streamlined IIF funding towards improving access. So this is
Yeah.
where they removed 31 of those 36 IIF markers and redirected that funding at access.
Yeah. It's important to remember that that funding was already offered to primary care, and they've just changed how they're going to allocate it. That's what's happened. It's not, again, additional funding.
Yeah, it was targeted at quality improvements, wasn't it?
Yeah.
To actually improve the specific quality of the care that patients received, and that's been retargeted at access. So that's where that money has come from. Deliver on equipment to make a further 385 million available for this is ARS money essentially, isn't it?
Yeah.
That has already been committed and announced and is part of the primary care network days contract running 2019 to 2024 as it continue to allocate system development funding. So this is funding for the development of ICBs and ICSs that has
Mhm.
previously been announced. Given the scale of proposed change, so this isn't funding, but NHS England will launch a major communications campaign to explain the evolving nature of primary care to the public and how they can best use the NHS. So you've often asked for this sort of thing, Gandhi. Are you
Yeah.
pleased to see this there?
Yes and no. So yes, that they've actually recognised that the information campaign to help patients understand the changes in general practice had to happen, needs to happen, and they are committing to delivering something. As we're going to find out later in the document, the method of doing that, okay, yeah. As ever, it seems to be a difference of opinion as to how I think it should be done compared to how the government thinks it should be done. But we'll come to that, I think, later on. But at the very least, it's mentioned, which is a good thing.
Did you break it down? What I hope it doesn't become is something that looks a little bit like political campaigning. I'm just early doors. I'm identifying
Yeah.
a risk here, given the nature of some of the stuff that comes out of Department of Health. I don't want to be too controversial, but I hope that this doesn't look like political campaigning. We are making available this. I hope it doesn't have that
Yeah.
flavour to it. I think we better move on
Yeah.
to some of these sections. So there is this section here, and I don't think we'll dwell on this very long. It's why we need a recovery plan to access primary care, and it really just talks about the pressures on the system, how the way people access has changed due to the availability of new technology and the aging population demographic issue, impacts of COVID. So it does just talk through those things, just highlights and acknowledges previous documents, talks about the shift to preventative and proactive care, all of these things that we've heard before. We just highlighted that there's just this graph here that we just wanted to react to, really, Gandhi. So this is showing an increase in the staff employed by GP practices over time. I'm just noting this is since 2019, so that's when the primary care network DES came into place. So that might be why they've selected that date. Any reaction, Gandhi?
Well, you made an interesting observation that when you look at the particular categories of the staffing and stuff, if you look at general practitioners, so doctors in general practice, and if you look at nurses, those two bands have remained fairly static and stuff. The increase has come from other direct patient care staff members and from admin staff members, which is not a bad thing, because actually, you know, particularly from an admin perspective, we absolutely need more administrative staff, in particular receptionist-based staff or care navigators that are now looking at being called and stuff, because actually they do a hell of a lot more than just reception duties. But important to recognize that, again, that those categories of doctors and nurses haven't really improved, and in actual fact doctors has reduced. So again, we're going to come back to this later on in the document. There is a key aspect of there just is not the capacity of the workforce to deliver the demand that's currently being seen in general practice.
Yeah, and of course, the doctors and the nurses are spending some of their time supervising the other staff now as well.
Which even more limits the availability of that workforce, because they're now having to supervise additional roles, which again is not necessarily a bad thing, because it allows that capacity to be there, but important to, and this is why I keep and repeatedly have said that there needs to be an information campaign to patients to help them understand these changes have happened, and that's why there is less availability of clinicians like doctors and nurses in general practice. But
just another observation I would make, and this might be a little bit controversial, really, but a lot of these additional staff are obviously employed through the primary care network ARS roles. They're people like social prescribers, health and wellbeing coaches, and they do a really, really good job that's really, really beneficial to patients. But it is very much additional to what general practice traditionally has been done. And actually, some of the things that we see those groups of staff doing now, such as organising community events to support people, doing what looks like support worker type work in some ways, and also even providing sort of weight loss management facilities, you know, within primary care networks and things like that. That's the sort of stuff that used to be funded through local authorities, you know, and local councils. And now we are counting that within general practice workforce. And I think that sort of distorts the picture a little bit. And I just wanted to make that point for people to take into account when they're looking at graphs like this. So let's continue our journey.
So it talks then about the problems for patients in practice. It mentions obviously about the access challenges and stuff, and in terms of how people struggle to get through on the phone lines, and actually how the difference of you know, the routes of access as well is a priority in things. And then it comes to this section about how you can make these changes. So that set the tone. What we're now going to talk about are the 4 key areas it recommends on making a change. And in particular, it talks about empowering patients. And there's 3 key aspects to this that the document outlines and stuff. Important to note, when it talks about most of these changes, it talks about ambitions and outcomes. That's a key process I think people need to understand from this. This is not saying that this is stuff you have to do. This is what they hope they can achieve, an ambition of the plan itself, and then what they see that looking like and stuff. And like I said, there's 3 key parts. First one, very much focused around the NHS app, isn't it, Andy?
Yeah, so it's about empowering patients. Then there's 3 key ways that they see this happening. So one is improving information and NHS app functionality. So they want to drive adoption of the NHS app. They talk about how that's been successful in reducing workload in general practice so far, and they focus on an example of reducing the administrative burden of issuing repeat prescriptions, which I think actually is a really good example. You know, sometimes we forget to celebrate, you know, some of this progress. I get my prescriptions on the NHS app, it is really simple. Seeing how that looks the other side within general practice, when a patient requests prescription via the NHS app, it is a lot easier, just fewer keystrokes, just less hassle and work within the practice to issue those prescriptions. Or even if you send a query, it's actually much more easy for them to forward that to someone who can deal with that query and get that prescription issued. So there is quite a lot of scope, I think, within that. They talk about increasing self-directed care where clinically appropriate. So that is self-care, advice essentially, and making that discoverable within the NHS app, as a front door, not necessarily the front door, there's lots of options in terms of the type of software and tools that practices can use for patients to access them. But they certainly are wanting the NHS to be a front runner there. And they talk about expanding the community pharmacy services. And maybe we'll scroll down and talk about that in a little bit more detail. You're right. They talk about ambition and then sort of how we will deliver. But this is guidance, as you say, and actually later on, they're sort of quite honestly say this guidance is supported by these contractual changes, and then they talk about the things within the statutory instruments and IIF and so forth. So they do make that sort of distinction between contracting and the ambition within this document. So they talk about the NHS app. They give that case study about repeat prescriptions, which are fantastic. Talk about increased self-directed care. So this is self-care information.
Go back, Andy, as well. I think one of the other things they mentioned about the NHS app is about using it as a process tool and also access to records, which I think that comes up again later down the line. But it does talk about directly booking appointments. Like you mentioned, repeat meds is a big one, but actually the prospective record access is a key feature of this. And you mentioned the contractual changes. So general practice from November this year has to switch on prospective access. This is a deadline that's repeatedly been delayed. It looks like this time around they are absolutely genuine that it will be switched on. The ambition is, again, 90%, I think, of general practice patients will have access to their prospective records by March 24. So there is a piece of work then. I think one thing's for practices and more importantly networks to consider, that whole stuff around their digital transformation leads, about care coordinators to support the transition to the NHS app, information to help patients understand how to register with and use the NHS app. And if you want some of that stuff, obviously GP Learning has a few guides for you on that. But that seems to be a key direction of this. So utilize some of those resources and share that with your patients to help them understand this as a route into the practice, because it very much now seems to be increasingly the NHS app is going to be the digital front door for general practice and healthcare as a whole.
Yeah, absolutely. And they talk about messaging within that as well, the ability to message your practice, which I guess, in simplest terms is a free text query, but that may look more like an e-consult in some cases with some structured information collection.
Absolutely. And a lot of the online consultation providers have been told that to continue on the purchasing formats and stuff, that they have to use the NHS app as a front door, so that actually that integration is seamless for many patients, so they don't see the difference of having to use different platforms, which is actually a positive thing. So then if a practice changes the way they use them, they're not asking patients to register with another way of doing things and stuff.
Yeah. So the other thing we've not mentioned so far is about monitoring long-term conditions at home. And they don't go into an enormous amount of detail on that, but there has been discussion elsewhere about home devices, SATS probes, blood pressure monitors, things like that, with some data flow into automatic systems or to clinicians to help people stay at home and monitor their conditions at home. Scrolling through, my scroll's a little bit slower today than I would want.
So the next section, like you mentioned, was about self-referral. Interestingly, different areas do different processes and stuff, but there is absolutely a focus on local ICSs having more support for patients having self-referral capabilities for certain things like musculoskeletal, IAPT resources, podiatry, audiology, various different criteria and stuff. And it does reference another document that came out in January, which we haven't actually covered in detail, but partly because it's massive, but also because it's about the focus of the ICS level changes and things. But I see this as a positive thing. I guess my tip I would have for practice is have a page on your website that directs to all the self-referral processes that you have, and then have that link on an Accurix or a SMS protocol or something like that you can send to patients and share with them about the ways that they can self-refer to various services. So that's easily available to send to patients, and potentially even broadcast as an SMS blast or as a notification blast to your patients every few months, so that they're aware of the various resources that are actually available, so they don't have to come through your practice to access and stuff.
Yeah, or tip for ICBs, PCNs, or collections of practice working together, particularly ICBs, to be honest. Make that aggregation page for your practices, because they won't all do it themselves. They're not all watching EGP Learning on a Saturday morning. So, so if you are from an ICB, then make it very easy.
A central page to do that would be even more effective, because then that's standardization of care. But I'm also aware that different areas have different boundaries, have different resources. There can be some variability. So I guess if a practice wanted more control of it, simple page on your website. These are the self-referral processes you've got. Most practices have this, but they don't advertise it. They don't share that with their patients and stuff.
And it's not too difficult to do, actually.
No. But the big one is about expanding community pharmacy, and this is the one that hit the headlines everywhere because of the fact that it's about a push of change of access and stuff. So it talks about pharmacists being able to support patients with minor illness conditions, which actually a lot of our pharmacy colleagues are really good at doing, both in practice, from a network pharmacist perspective, but also community pharmacy, which does a huge amount of work. Let's be honest, they do crap loads. But it's interesting that they've kind of rebooted this whole concept of a pharmacy first scheme, isn't it, Andy?
Yeah, it is. So they're talking about making it easier to connect people with community pharmacies. So they're talking about referrals in from NHS 111 to community pharmacies, which I don't know if that happens currently anywhere or everywhere. It's not something I'm too familiar with. I think they might just give verbal advice sometimes, but I don't think there's an official way of doing that, which I think is what they're talking out here. Also, yeah, they do the medicines resupply thing, don't they? Out of hours. I think that's something that happens, but they could certainly expand that connection between those two services. They're talking about community pharmacy support. I think this is something they already do. 200,000 people when they start a new medicine. I mean, I'm sure they offer support, but I don't think that that's something that is new. And then they talk about pharmacies that have already done blood pressure checks and expanding that, and the community pharmacy contribution to the vaccination program. So lots of stuff happening in community pharmacy. They want to build. So those are all happening already, and they want to build on the success. How will they do that? So the new Pharmacy First scheme, or reinvention of the Pharmacy First scheme, and they're looking for a role with certain minor conditions, and they name a number of them here. So sinusitis, sore throat, earache, infected insect bites, impetigo, shingles, uncomplicated UTIs in women. That's certainly appropriate to restrict it there, where they don't need to visit a GP. And then also adding some more long-term management roles around blood pressure and around oral contraceptives. And they don't really talk about the particular sort of protocol that they would be following there, or inclusion or exclusion criteria, but just highlight the potential for building on what already happens, and actually the preventative value of addressing high blood pressure more effectively. They touch on there, and the downstream savings that might have for the NHS. So any thoughts, Gandhi?
So there's two that I've got. So one, it mentions in that concept of those 7 conditions that it talks about making sure there's consistency in prescription of antibiotics, antivirals between primary and second, between primary care and community-based pharmacy. I think that's a really interesting thing to be aware of. That obviously one of the concerns that many clinicians potentially have, that general practice has done a huge amount in terms of antibiotic resistance management, and not trying to prescribe antibiotics inappropriately, because we know antibiotic resistance is going to continue to have a massive impact on the health of our population years to come. And in some circumstances they put it on a par with the whole environmental challenge that we're facing in terms of the risks to our population as a whole. So having an understanding that actually just dishing out antibiotics for everything is definitely not the best route of action. I think there are some concerns that this scheme may support that, although it hasn't really in previous elements and stuff. So important to recognize that part. The second thing I wanted to mention is the interaction between these schemes and the general practice notes. Now it talks about this later down. So if you scroll down, Andy, it comes into something about connectivity, IT system connectivity. So if this scheme is to be used more effectively and at a point where it can actually help populations and patients individually, there needs to be some sort of reciprocal information sharing process, because otherwise you could potentially have patients who are going to pharmacy services on a monthly basis, for example, having treatment for example, an uncomplicated UTI, going to a variety of pharmacies because that's been convenient to that patient. But actually, if that's happening every month, that's a bit more of a concern. Is there something else driving this? And the practice may not even be aware that this is an issue until it becomes a concern. And actually, is that then because there's an underlying health issue that has more significant consequences that's not been picked up because that information sharing hasn't been there? Now, obviously, I'm talking about things that therefore means patients should be contacting the practice. Should they for everything? No. But there needs to be some sort of mechanism in there to understand at what point actually should this not be dealt with in the pharmacy, and how can that help the patient's individual healthcare and stuff. So it's just, I would love to see the tie-in of how this information is going to be shared, made appropriate. And the other thing that it hasn't mentioned is whether patients will be paying for these prescriptions. So obviously, if you and I work in deprived communities, one of the challenges we've seen with this CPCS scheme, which there's no mention about this one, we've got a community pharmacy consultation scheme, which is funded for in pharmacy based, but actually the patients then have to pay for the treatments. That's been one of the reasons why there's been some hesitancy in patients using it, particularly from our communities, because then they have to pay for the treatments. Well, how does that work with these issues if patients are having to pay for the treatments? And my final point, because I know we want to move on, I mentioned earlier about that thing about 10 million appointments. Yeah, remember when we were talking about the increase in age groups and stuff, and that actually there needed to be 10 million appointments? According to the government, the funding they are given to provide for this increase in minor illness pharmacy scheme, the Pharmacy First scheme, they're offering £645 million of funding, and we don't know where that's come from, whether that's additional or not, to provide over 2 years 10 million additional appointments. That's how much they see this being provided. So that's approximately £32 an appointment. Imagine if general practice had that level of funding to actually provide appointments for patients. Now, let's be clear, the pharmacies will not be getting £32 per patient. I can't see that happening. There's going to be some that's taken in system usage, management costs, training, all the other stuff, just to reuse some of that. But just imagine if that funding had come to general practice to provide additional capacity. Actually, there's your resources potentially to provide the capacity that you potentially need from the workforce.
Yeah, it's £190 an hour, isn't it? It's an awful lot of
it's a huge
money.
amount of money.
Which certainly more than pay the wages of a GP to do that time. But I guess the GP workforce isn't there, and there just must be a lot of friction, setup, administrative costs to doing this new thing. You sort of wonder if you just train more GPs and sit more GPs there to crunch through this. Would that have been a better approach? But then I guess there's the training cost of the GPs. The true cost of the GP is not what you pay the GP in the room. In the same way that the pharmacist won't get the £32. They then talk, and I don't think we need to dissect this, but about greater flexibility in terms of pharmacy contracting and payment. And I'm going to suggest that we don't go into that.
Yeah, I'll pick up one thing though.
Unless there's one bit that Gandhi wants to look at.
No. So there is. So there are some really interesting stuff in here, and I think for a pharmacist, community-based pharmacist, this is going to mean a lot more than myself and Andy, because we're not a dispensing practice stuff. It talks about cutting VAT. I'm guessing that's going to have a financial benefit. It talks about increasing the roles in terms of pharmacy technicians being able to do PGDs, which means that they can administer more medications, which probably will help with the capacity, because actually community-based pharmacy workforce is also massively reduced because a lot of them are now working in primary care networks. And something about packs and stuff that will help in terms of hub dispensing, so in terms of sharing information. The reason why I wanted to stop Andy, because I know that he was moving on to the next section, there's one massive thing missing from this directive, which actually I think would have more of an impact than everything else mentioned, including that £645 million. And that is simply to allow pharmacists to change prescriptions when those items are either not in supply to the most sensible, appropriate item, because the amount of workload that creates both for pharmacy and for general practice, because of those legislation issues that happen in terms of the changes, and because the government doesn't want to pay for higher cost items in those situations, would have had more of an impact to everything And in terms of the bureaucracy busting stuff that we come to later on, massively would have made a better improvement in workload for general practice and community-based pharmacy, and more importantly, the patient experience. And they've massively missed a trick on here.
No, absolutely. I mean, in some areas you can use your PT and pharmacist to do a bit of that work, but actually just even that's superfluous, isn't it? Just let the community pharmacists themselves, make the changes. And often the changes we make are what they are advising us at the end of the day, because we don't know what alternatives are in stock or not. That's knowledge that is within the pharmacy. So yes, good suggestion, Gandhi.
I mean, I'm sure there are patients out there that have had the experience where they've had to go back and forth between practice and pharmacy because the two can't talk to each other easily about what is actually in stock in the pharmacy versus what is sensible for the conditions to be prescribed. But giving pharmacists who have a lot of that knowledge to take at least, I would estimate, about 70 to 80% of that away, because it's just a change of brand, it's just a change of form often for many of these things, would save so many patients time, frustration, and more importantly, from the practice perspective and the pharmacy perspective, would make that process a lot easier. And they have missed a trick by not including that anywhere in this documentation.
So moving through the document, just doing a quick time check on us.
We're
a little bit behind time relative to where we wanted to be at this point, but bear with us. We will get through the rest of the document. So implementing modern general practice access. So they've made this is a new phrase, modern general practice access, and they sort of put it against or set it up against traditional general practice access, which is now bad, and modern general practice access is good now. So just interesting use of language, and I suppose their change management consultants, might have told them that they need a particularly catchy way of framing this change.
Brand
I guess.
It freshly, yeah.
Sorry, Gandhi.
Brand it in a new way.
Yeah. So, and basically, modern general practice involves better digital telephony. They talk about this a lot. We'll talk about that when we get to that section. We've discussed it before. Simpler online requests and faster navigation, assessment, and response. Those are the three components of what is defined within this document. So, modern general practice access. I think it's the first time that we've met that. They encapsulate it sort of in this diagram, really. So there's the traditional model and the modern general practice access model. The second one actually is looking like how we're redefining our access system actually, and is fairly sensible. What did you make of these diagrams in this framing tool that they're using to define the difference?
I mean, it captures what I think many practices are trying to move towards. There's that change management aspect of can they do that and what resources they've got to do that. And it does talk about some of that later on in the document and things. But I think the modern general practice one is also very simplistic. It seems to suggest that this is going to solve all the problems, but actually what they haven't looked at is that right-hand cat, kind of thing in terms of the assessment and stuff. Well, what happens when there's just not the workforce to deliver the outcomes, and therefore part of the reason why patients may end up still bouncing around the system is there's just not the bums on seats to deal with the issues that they need.
Yeah, absolutely. And also, I don't think they've done the traditional model like justice, because there's only a face-to-face appointment with the GP, and we know that no one's doing that anymore. There are always telephone appointments, and there are other people as well as GP and nurses that work everywhere, within the system. So I don't think they're characterizing traditional very well either. And as you say, signpost to local services or self-care, that's all well and good, but actually that's going to drive a lot of traffic to the walk-in centres, particularly to the emergency departments and other parts of the system that they may not be resourced to handle. And also the GP practice still will need to resource their own GP team to see the people as well. It talks a little bit about addressing that in the long term, but not there are certainly no answers within this document that will deliver fruit by the 15th of May, on Monday, in 2 days, considering this was released last week. So interesting. Just find out the highlights
about care navigation. I mean, it talks about better telephony. Now, we're not going to go into this in detail because it talks about the concept of how cloud-based telephony can help with callback features, queuing, call routing, and that kind of stuff. You can see them highlighted there for you. I guess if you want to know more about cloud-based telephony and the benefits, both from the practice perspective and from the patient's outcomes, definitely join us for a different stream that we'll be doing, which is with some of the providers in the coming weeks and months and stuff. And we've got one of those due in a couple of weeks' time on the EGP Learning channel. So at this point, I'm definitely going to suggest, if you haven't already subscribed to EGP Learning, do so you can get notified of it at the time that that is coming out. But I think it's 2 weeks on a Wednesday, live stream coming up, talking more about cloud-based telephony and stuff for you.
Yeah, absolutely. And yeah, the telephony doesn't solve the problem of having people to actually physically pick up the phones and people to actually perform the actions, of course. But it will. Yeah.
Repeatedly, we're going to see throughout this that they haven't actually considered the workforce elements to some degree of this things. But why would they?
That's fine.
I think there is some benefits that, in terms of cloud-based telephony. I'm not at all discounting the fact that it will have some impact in terms of abilities, particularly remote working. It can really help on. It does talk about online consultation requests next as the topic, as Andy has shown us and things. And I think part of this is also because they are planning on funding the online consultation tools directly through the GP contract, from what it suggests. Still not 100% clear on that, despite reading it a couple of times now. But the fact that actually this will be available for practices to support and use for their patients' care. It talks about some examples whereby it's not just about patients filling in information. Actually, you can have supportive stuff done by care navigators, which we'll come to in a second. But actually, there's a really good information there about some appointments don't need to be an appointment. And we know this. There are definitely some contacts that do not need to be a physical face-to-face appointment, because actually it's just about clarifying information, review of information that can be done through other means like an online consultation. And there's some really cool tools out there that can help you with that.
There are, yeah. And just to pick up on a comment you made about the funding. So this statement is note 53 to make available high quality online consultation machine booking tools available to general practice. To do so, we will change the tools available on the digital care services catalog by introducing a new group of fully funded products. Interesting.
So the booking one's really useful as well, because actually there's some recent papers that came out that showed that some of the providers that give self-booking features potentially could save millions in terms of costings for general practice in particular, because of the automated routes that they can help provide appointments with and stuff. So yeah, it's definitely a positive thing. I think it's just unfortunately a lot of the focus has been that the funding for general practice delivery is around a fancy new telephone system, not bums on seats.
Yes, absolutely. They talk about improving practice websites and giving ICBs, tools to enable them to do that. We'd highlighted this case study, Gandhi. Did we want to talk about that?
So again, it talks about the differences of using a cloud-based telephony system to help support patients in terms of their access and online consultation tools in addition to that. So one in particular uses artificial intelligence to help. I think, again, they can be really useful if you've got the time and space to integrate those within your practice, and also inform your patients about how to use them effectively. And it will help a majority of patients. It won't help all patients. Still going to be cohorts who absolutely need telephone, who absolutely need face-to-face access and stuff. But that's where this next part, in terms of care navigation, comes into play.
Absolutely.
Just we've had a few there for you, Andy.
Yeah, we've had a few questions, haven't we? I'm just wondering what your reaction to. We just had, will other apps die? So this talks about, it was Clinic, wasn't it? Was the with a K, was the app in that case study. I mean, I know a lot of apps will integrate with the NHS app anyway, or can be displayed within the NHS app. Some can't. I mean, will other apps die, Gandhi?
I don't think they will die. I think there's a focus, and I mentioned this earlier, about the digital front door being the NHS app. So other things will sit behind it. So if they don't sit behind it, I think those are the ones that are going to struggle. But as far as I'm aware, almost all of the online consultation providers are moving towards having a digital front door being the NHS app, because they're looking at that integration. It has huge benefits in terms of identification sign-ins and that kind of stuff as well, so that patients are using the appropriate resources and stuff, and potentially even proxy access. So, there is some really beneficial uses of sitting behind the NHS app, and that streamlined experience for patients in particular, because actually then it doesn't matter what system your practice is using, you will have a similar experience across the board, which I think is a really important part for this in terms of if we are looking at proper access and stuff.
Absolutely. So the next section talks about faster navigation, assessment and response. So this was really a core part of the changes to the core GP contract, wasn't it? This
Yeah.
ability to make an assessment after people are presented to the practice and deliver an appropriate response. So, assisting the patient with care navigation to get the appropriate response is a key part of that. And they talk about making training and tools available to improve care navigation after patients contact practices, which sounds good. There's going to be a new care navigation training program for up to 6,500 staff, which doesn't sound that many actually.
So I'm going to pick on this one, Andy, if that's all right. So what this effectively means is that they are providing a information package tool to help upskill existing members of staff to become care navigators. The reason why they said 6,500 because there's 6,500 practices in general practice.
Champion.
So one member per staff per practice effectively is what they're looking at. Now that's great if you're a medium-sized practice, because potentially you'll have the staffing to release someone to go off on the training, and actually you're not going to be too big that only having one member of staff doing that care navigation to then disseminate that information to the rest of your team is sensible and appropriate. However, if you're a really small practice, it's 2 days worth of training, so releasing them to have that training and then do that can be a real challenge because you may not have the workforce to then compensate for that. Similarly, if you're a massive practice, having only one person do that across your entire administrative workforce seems like a drop in the ocean. So I think this is just, it's frustrating in some ways for me.
Yeah, so it's interesting. They talk about the care navigation competency framework. So I remember back in, I think it was 2018, developing some training for local GP surgeries based around that competency framework, which is actually a really useful tool for developing and training from and training people to. And that was part of some one-off funding associated with the GP Forward View document back at that point in what is now history. And the trouble was that was some one-off money to do some one-off training. And despite efforts locally to try and sort of develop a community of practice, and retain those skills, I think a lot of those skills decayed over time. And I hope that the same thing doesn't happen. If you want to create a body of, professionals or people with a role, you need to support that to continue. We are GPs, we do appraisal, we do ongoing training and, training exercises and CPD. A lot of that is funded. Some of it is self-directed, and that retains our skills. And, without a similar approach to care navigators, it might just be another one-off piece of training that doesn't get traction. So I'd like to see some recurrent effort to do something around care navigation. Maybe that will come. So
as we scroll down, there is one more thing I think that's important to note, and it's one of the few times that we've actually seen some documentation around this. And I can't remember exactly where it is. It may have been in this section or not, because I can appreciate
Andy.
But basically, it talks about the fact about patients sharing information with their practice team. So in documentation, somewhere in this document, apologies, we can't find it right now, it probably may come later, it does talk about patients being open enough to share their information with their practice team. So why am I raising this? Often we hear that patients don't want to talk to our front of house team, the receptionists or care navigators, because they feel that there's a confidentiality aspect there that they don't want to incorporate. Actually, NHS England, the government, are telling patients you need to start doing this. So there is documented elements that show that patients need to consider that this is something they need to do. Now, it's not going to be for every single situation, absolutely, but that whole concept of I shouldn't have to tell the reception team what my problem is, that's no longer there.
Absolutely. It's been a while since I've come across a practice where that's the case, but I'm sure it is, in many places. I'm sure.
I think the reason why I'm labouring this point, I think there are definitely still contacts and patients out there who feel that they shouldn't have to tell the reception team what their health issue is. The government, NHS England, are now saying, actually, this is part of the experience you will have in general practice. That sharing the reason for your contact is something you should be doing because it will help improve your experience of general practice and primary care, and actually taking that view that you don't have to tell the care navigator team what the problem is, is actually going to impact negatively your exposure to general practice. Important focus to have, and I think it's a really supportive aspect for practice teams to be aware of, that this is now actually written within the guidance and contracts that we should be doing.
Absolutely, that's a very good point, Andy. So building the capacity to do this. So earlier in the document, they were talking about the building challenges around general practice, and capacity within general practice, GPs, nurses, general workforce, administration is a big problem for making all of these things happen. I mean, it just happens that a lot of it needs to happen by Monday morning, which is a challenge we're all grappling with. The biggest parts of the changes, the 8 a.m. rush. So it talks about how we can build capacity to support that when it's happening on Monday morning. So interesting section. They do acknowledge GP numbers are not where we would like them to be, is the statement that they give. And it will take time to train higher numbers. And they want more. They want to train more GPs. It's a little bit vague, actually, in terms of how they're going to make that part of it happen. And it's not long before they start talking about buildings and other things. Have you got any tips for them?
They know they can't do it. That's the reality. It takes 10 years from point A of someone joining medical school to point B of having a general practitioner to develop a GP. That's not something they can turn around. If they had wanted to, they should have started this way back when 2013, 14, when the government came into power, but they haven't done. That's the problem. And actually, we're seeing a reduction in GPs in particular, and almost every other type of clinical-based workforce in general practice. So I think that's part of the reason why they're struggling.
Yeah. I think actually they do give a little bit more detail later, and they do talk about bringing retired doctors back and retaining people with pension changes. So we'll cover that in a little while, but even then it's a little bit vague in terms of the new training numbers, to be quite honest. Pressure on estates. So they're going to, so something I pulled out here was they're going to support the development of a new standardized design for primary care buildings. So this immediately conjured images of, how every McDonald's built between a certain time frame kind of looks the same. It's got a similar modular design. It sort of brought images of general practice buildings kind of looking the same, which I thought was interesting. I'm sure there'll be some local variation, and particularly in areas of natural beauty and so forth, things might look different. But I just thought that was an interesting concept. And actually, maybe it's more efficient to design once and build many than everything be bespoke. So that was interesting. So they're going to build this capacity through large multidisciplinary teams, more doctors, retention and return of experienced GPs, and higher priority for primary care and housing developments, which I think you're going to talk about a little bit more when we get there.
So some of this, we can go through fairly quickly. The larger multidisciplinary teams, let's be clear, this is the additional reimbursement roles scheme, the ARLS roles that we have from primary care networks. That's what they're focusing on. I think they're really happy about this because they've almost reached their target, 26,000, by the end of year 4. So that's why they're crowing in a sense about it. But important to remember, what it mentioned in this document is existingly planned funding. It's not additional funding. It's not additional resource. This is stuff they already had planned from way back when in 2019, and they're just confirming that they're still going to keep their agreement of what they're going to do and have that workforce there, which is not a bad thing. Again, having that additional workforce, but important to remember that is not GPs. It's not necessarily nurses, although that's one of the new roles added in as of a couple of weeks ago. But important to remember this is not additional in the sense of what people were thinking would be even more workforce coming through and stuff.
Yeah, it's all planned for. It's already the funding's already been announced for that, but it is coming. And I guess specifically, it is not GPs and it is not practice nurses. It is other members of staff. There's a nod towards wellbeing tools being made available for practice staff. So I mean that's good. It's a nod in the right direction, I think. They talk about changing how ARS staff's appointments are coded so that they will definitely show up in the general practice appointments data. Fair enough. There's an interesting case study about using ARS roles to take the pressure off general practice. I think they talk about first contact physios particularly, as well as other roles in there in terms of lifting pressure. And I think that in our primary care network, that's been probably the main role that most directly takes work out of the general practice stream. I know you have physicians associates, so they probably do a similar role. to your FCPs. So more new doctors. So the NHS long-term workforce plan will be published shortly. So that's where the answers will come, I guess, in terms of where more GP
Supposedly, yeah.
will come from. So we'll look out for that document and we'll have a look at it when it comes out. They talk about offering access to fellowships to all 2-year fellowships to all GPs completing when they complete their specialty training, which is good. Those schemes have been quite successful locally. That it's saying access to, not making it a compulsory way of extending training, but offering access. So that's good. And there's £35 million of funding to support that, which doesn't sound like an enormous amount, actually. That's good. They talk about some flexibility for international doctors completing GP training to remain in the UK for a longer period of time in order to find a job, to enable them to stay in the UK, and sort of streamlined and more encouragement in terms of allowing employers to access the right sort of visas and permitting for it's not. We've never taken one of these on, Gandhi, or really explored it, but it can be quite difficult to do what you need to employ an overseas doctor so that they can either come or stay in the UK, and they're talking about making that easier, essentially.
I think anything that makes the process easier is going to be a positive, but actually one of the things that's important to remember, that you are talking about clinicians that have had a different type of training and experience, so therefore there also needs to be that onboarding element for them to understand how to work more effectively in UK-based primary care. And important to also recognise that those, unfortunately, are the cohorts of doctors that tend to have much higher complaints because of either patient perception or because of difference in communications, training, etc. So, absolutely, in terms of supporting more of our colleagues to work here from an international perspective. But let's not also forget we're talking about a government that's been very anti-immigration, anti the perspective of people coming from abroad to work in the UK, and gone on a rhetoric that they want homegrown talent, and yet all of our homegrown talent is leaving because of some of the policies and processes put in. So kind of reaping what they reward to some degree. If I'm being
Let's not get
honest.
too political. Just in the interest of BBC style balance, I guess the government would say, actually, we talk about a points based system and skilled migration. I think it's more the people on the boats that they're more hostile to.
True, but then also I hear many comments of colleagues that are being told that they have to leave the country because they don't have enough points, even working in general practice. So some of this to change that, definitely a positive in terms of increasing the workforce that we've got. The final thing it talks about is a really interesting and political thing in the medical politics side, is the concept of SAS doctors. So I forgot what SAS stands for, but it's basically
service grade, isn't it? So it's non-consultant hospital doctors, essentially, who have completed training, but have not, for whatever reason, gone on to take on consultant roles. It's talking about, and they've never been part of the general practice workforce, but it's talking about giving them opportunities to work within general practice. Why would that be controversial, Gandhi? I can think of a few reasons, but
I think it's controversial because the whole concept of GP training is to condition you to become an independent practitioner, and that's one of the massive differences between hospital-based working and primary care-based working, that you are very much more independent in the work that you do. So therefore, you don't have the hospital sitting behind you as an engine house to provide support and protection, and in terms of that kind of stuff. So there is one of those concepts. There's also the fact that there's this issue of the performers list, that you can't actually practice independently in general practice unless you're on the performers list. In order to do that, you have to have had your CCT in general practice to do so. So that there are some legislation issues there as well. I think the other aspect, though, is that because you are working so independently, how does that work with the other aspects of primary care? If you're working under a training prospect like a foundation doctors, GP trainees, there are safety processes in place, and there is funding and resource to support that. From a SAS doctor perspective, there probably won't be that, because they will see these as independent practitioners, even though they don't have the relevant training to allow that currently. So therefore, what happens when something goes wrong? Who's responsible? And we do need to think about these factors and issues, in my view, because actually that's all the practice is then a responsibility to manage that. And as a partner, actually, is that the best use of the resources that I have in order to provide care to my patients? It inevitably comes down to the individual, not necessarily down to their training, and actually that's where it becomes more complex.
Yeah, I think you've articulated that well, really. It is just very different working in general practice, and all doctors working in general practice are either very highly supervised by, actually, a well-trained and resourced supervising senior doctor, or they've completed 3 years RCGP and are very capable independent practitioners. That's very different to service grade doctors who are very good professionals, but will be working under the supervision of a consultant within a hospital.
And important to remember that working in general practice is significantly different to working in a hospital environment or a single condition-based environment where many of our hospital-based colleagues tend to work, because they work on a specialized area, not the generalism of general practice. And more importantly, recognizing normality, which is a huge part of general practice.
Just reassuring people out there, we're not too far away from the end of the document now.
Yeah.
But they also want to retain GPs and return GPs who have retired. So various things around changes to the annual lifetime pension, contributions limits, and yearly contributions, which were announced in the last budget. Easier to retire and return, and support various schemes that are already there for people to return to practices after periods of absences, essentially. And actually, GPs who have been retired, they say, oh, might return to general practice or to support 111. It's something that's particularly raised as well, which is something that happened during the pandemic. To some degree, I don't know quite how many GPs came back to those roles, but that's something that happened during the pandemic. So
really small amount from what I've heard, but hey,
that's what I heard as well, that it was not really that significant. And how much primary care and housing developments? Go on, you want to talk about this, Gandhi?
I do. So important to recognise that obviously the housing expansion is currently happening in the UK. We don't have enough properties for people to sit and live in and stuff. So therefore, there is a massive expansion, particularly flats in inner city areas and stuff. And there is this concept that actually, are the general practice estates satisfactory for the needs of the healthcare provision of our population? And the simple answer is no. Everybody knows this, that general practice estates is an absolute shambles, and that actually there is often not the room, the space, or the services to provide healthcare effectively to a community. This is therefore exacerbated in areas where you've got increasing development of properties, increasing number of places and stuff. So this part talks around very much a focus for the ICSs to focus on making sure that the provision of estates is considered. Now, they should already be doing this, okay? The local authorities should already be doing this. The local areas should be doing this, but they haven't been to a significant degree in many places. This part of the document focuses that actually it's the ICS's responsibility now, because it's a combination of health, social, and all the other aspects of care, to make sure that this is considered and reviewed. And I'm going to mention this quite clearly because in my local area, there are at least 4 significant high-rise flats currently being developed. It's going to increase the population of my network, estimated by another 3,000 patients in the coming year once those flats are developed. The practice teams we have, our estates are already filled to the brim. We do not have the estates to cope with that level of number of patients coming into the area. Their experience is going to enhance the problems that they will face in terms of general practice access, but more importantly as well, the existing patients that we're looking after are going to have more challenges, and general practice is getting none of the resource from those developments to support that, or the estates management support to help deliver that care. So this being there is a useful thing. I don't think it's going to fix the problems, but at least it's in there. And this is something I think many practice areas where they are seeing high development of residential areas need to be contacting their ICS to say, what the flub are you doing?
That's a really good point, Gandhi. I guess now practices can go to the ICSs, with a document and say, look, this is part of the delivering improved access to primary care recovery plan. Are you doing this? So it is helpful in that way. And you raise an interesting point because near us, so we're a bit more low rise, aren't we, Gandhi, out in Ball and Top Valley compared to you guys near the city centre. So we do have new housing developments springing up nearby, but generally they are low rise 1, 2, 3 story houses and low rise flats. And actually, it seems that developers often will make provision for sometimes will naturally make provision for a new GP surgery, but you're talking about increasing the density of housing within already built up areas. That's quite different, and I hadn't really thought about that difference before, really. But it seems less natural to as you're building lots of new high-rise flats in a city centre to automatically think about building a GP surgery as well, because they're not all the same developers. It's all happening a bit more organically. So very interesting point. I don't want to get too sidetracked with it, but I hadn't thought about that before. Good.
So next up.
Yeah, so just scrolling down, but we're really moving towards the end of the document now. Cutting bureaucracy, and it makes reference to this bureaucracy busting concordat, which we've done another video about, which we'll talk about. And actually, I think most of what it talks about actually is within the spirit of that document. So, so the first part is improving primary and secondary care interface. And they want to lower the friction and the administrative burden as information and patient flow between primary and secondary care. Particular areas to focus on are onward referrals. So, I mean, we all know often we get those letters from consultants saying, actually, please, I've seen them. It's not a gastroenterology problem. Please refer them to the cardiologist. And that shouldn't happen, but it still does. It wastes time for patients and GP practice and the hospital departments probably. They just send the same letter to cardiology. It would be, it would be fine. They could consider that a referral. Completing fit notes. We've already heard about changes in this area. It's now possible for FCPs, first contact physios, for example, or physios to do sick notes. There have been pushes to get hospitals to complete fit notes in A&E departments and post-surgery and post-discharge. And making that more common is part of this. Call and recall. So I think this is about people who are needing follow-up and tests. Again, help me out here. I'm just trying to remember what this section was.
An example of a patient being seen in an outpatient clinic and told you need to have a repeat ultrasound in 6 months' time, and secondary care delegating this responsibility to primary care rather than holding that responsibility. Or, for example, a patient who's had an echo test and been told you need a repeat echo in 2 years' time, I'm now discharging you from clinic. My interpretation of this is that should not be happening. That call and recall mechanism is now the absolute responsibility of the secondary care team. They've requested that test, but in order to get them off the books, to manage the waiting list and everything else, cutting them off, and therefore actually there needs to be a call and recall system, just like general practice has, but actually it needs to be held by the specialist because they're requesting the test. What's really interesting is a lot of this stuff that it mentions and talks about is listening to feedback from primary care about some of the challenges that we face with having to do secondary care workload inappropriately. There is absolutely times where primary care should be supporting secondary care with some of this workload and stuff, but actually there are clear examples given here about when it is inappropriate, and actually that responsibility should be held by the secondary care team, particularly with the left shift of patient care towards primary care being unfunded in many areas.
You've given a very good explanation of that. Yeah, absolutely. And you see this in some areas, don't you? I know the cardiologists locally will have, a recall register, for certain patients with valvular heart disease, for example. So I guess it's just about clarity about where that responsibility lies. So that's where this document is really, really helpful. And then building on those systems that are already there. It is possible within secondary care. It just needs to be done. It also needs to be funded as well.
Absolutely.
They don't have the money tree either.
And one thing I'm actually quite excited about this guidance and stuff that it has here, although it talks about, secondary care managing its results and all that kind of stuff in the first place, point 4 that you've got there on screen, clear point of contact. So actually there should be a point of contact for primary care to direct inquiries to. So that's things like advice and guidance, but also in terms of specific clinical areas, when there are confusion or challenges or questions around a patient care, because of that interface and stuff, because actually right now it's so disjointed, and let's be honest, secondary care has staffing challenges as well when it comes to this side of things. So getting the right secretary for the consultant team, getting the right clinician, all that kind of stuff, it's so nebulous at times that having a unified place that is then held responsibility by the secondary care teams to navigate where that query has to go to and getting a timely response is really going to help the patient journeys. More importantly, having the patient being able to manage some of that as well in terms of things like appointments and stuff more effectively, absolutely game changing for many patients' experience of secondary care contacts and stuff, and not having to come back to primary care for everything, which is adding to the challenges that we're having, because we're case handling a lot of these patients because of the backlog and stuff.
Yeah, I was just thinking the same thing. I mean, if included within those efforts are a way for patients to contact their secondary care teams, even electronically, if not speaking to somebody, to find out when their next appointment is, and let them know of changes to their health while they are waiting for their next appointment. That would be really, really helpful, because often general practice is just the middleman passing on this information, which is a waste of time. So building on the bureaucracy busting concordat. So they've given some examples here, but this is a document that calls on other parts of the government and private industry as good practice to be responsible in terms of the requests it makes from general practice for information, and letters to support their own activities. So I guess navigating the sort of public sort of council housing system, might be an example of this. Requests from Department of Work and Pension for work capability assessments are definitely, a big part of the workload at my practice, and actually streamlining what information they ask, how they ask in terms of standardized forms, how they want to get that information back, using actually, request portals. They were still asked for handwritten forms, in a lot of cases, and where we can quite easily generate automatic responses to populate a letter. We still get it in the form of a request for a handwritten form. So these things can be quite old-fashioned and can take a long time to engage with. I think they also talk about within the Concordat document, systems for limited access to patient records with the right permissions and so forth. But they give examples around working around aviation industry and fitness to fly letters. They talk about courts, and particularly around requests for information around jury duty is highlighted as a specific example, and local authorities around social housing they mention as a particular thing. But I mean, blue badges as well. I know locally we never used to have to produce information around blue badges, and then I think the council just changed their policy a little bit, and we had an influx of requests for information all at once from people renewing their blue badges, and that placed a lot of additional pressure really on the practice at a time when we didn't need it. So that's just an example how kind of small changes, or people in other departments in government, making changes, not realizing the impact that might have on other parts of the system, like general practice.
And I think it's recognizing the challenges of that lack of awareness of the impact, isn't it, Andy? Because actually, things like that example you gave about the blue badges, that's not actually considered NHS work. So there would have also potentially from the practices been a response of actually you need to pay for this access or this information, because you're taking away that access for things that we are meant to be doing versus things that are not contractually, and therefore we shouldn't be providing. And that would, of course, create conflict, potentially complaints, and more issues in terms of access and stuff. So absolutely, the Concordat is a really interesting thing for people to look at. And if you want more information, definitely check out the episode we've done down below that will be linked in terms of explain the bureaucracy busting Concordat in more detail for you.
So we're nearly there. Last two sections, and they're not long. So first we'll talk about delivering the plan, and then we'll talk about engaging the future of primary care. This plan. So they talk about who's accountable. So they're asking ICBs to take the lead, and just highlighting that they are now responsible for commissioning of general practice services, so contract management. So they are in the position to manage the system to make these things happen. They're just naming the fuller stock take as an ICB document, a document pitched at ICBs to aim for, and they would like their plans to align with the vision of the fuller stock take. And then they just highlight that they have supported the ICB's role in commissioner and contract manager by making changes to contracts. So they talk about the new contractual requirements, which I think will be the statutory instrument to change the core contract around those GP access rules and the appropriate response. That's the thing that comes into effect from Monday the 15th. Contractual incentives, I think they're probably talking about IIF funding. I think then they're talking that they've reprioritized some national funding, and we talked about funding further up in the document. in greater transparency the outcomes of the systems. So I think they're talking about the various dashboards, GP appointment data, and other ways that they are providing data to support ICBs to contract manage general practice, to deliver the changes that are planned, and the ability to leverage the existing standard trust contract. So that implies those changes that are outside of general practice, at hospital trusts and other organizations, just highlighting that the ICB have the power to influence their activity through standard trust contracts. So things like the interface between primary and secondary care will require some engagement with secondary care, and they're saying they have the instruments to do that. There we go, just name dropping the IIF fund as well. Oh, highlighting that 30% of the redistributed IIF funding is sort of discretional for the ICBs to award upon PCNs achieving agreed improvement plans. So they have some leverage in terms of that mechanism to make this happen. So that's what they've got to do with. Sufficient, Gandhi?
Yeah. No comment.
They'll have a go. It's a huge it's a huge ask, isn't it, to transform?
It is a massive ask for ICSs and stuff. I think more focused in this particular section in terms of delivering the plan, the transformation support, and I think this is something we want to spend just a minute talking about. There's a lot of detail here, and I appreciate we have run massively over our planned time for this section. So I think
we're nearly there, though, Gandhi.
Yes, we are nearly there. I think one thing we'll mention is that this is a section, particularly for those practices who have already been identified to having access issues, to potentially pay some focus to. It is additional resource and support in terms of looking at transformation from your current system to a different system of how you do access and stuff. And there is some evidence that has shown that previous practices that have gone through this process have had a really positive and effective experience, although as with anything, any change management is always a stressful experience, both for practices and for patients and things. It talks about supporting an additional 1,500 practices in total, I believe, and there's different levels of funding that it can do, but you need to be talking to your ICB about this, basically, because they will be determining who that is.
Yeah, so in brief, they talk about kind of three tiers of support, and there's sort of a series of webinars and toolkit, available to everybody, and they call this sort of tier 1 support, and then they talk about tier 2 support and tier 3 support, which it looks like it will be something evolved from that Accelerate program. I know neighboring practices have had the Accelerate program where people from an NHS consulting service come in and look at your appointment systems and do some audit of appointment demand and activity and make suggestions for changes. And anecdotally, they've said they've had very good experience of that. They've felt that it's been useful engaging with that. Whether that actually carries through to their GP appointment data, and actually benchmarking any different practices who have not engaged with that experience, I don't know that I see that yet in data in my area. But they talk about, so that sort of approach with someone coming in will be available to, this is the 1,500 practices, and those will need to be nominated by their ICB. So I think there'll be something about practices being asked to volunteer, and certain practices maybe being nudged by their ICB to go forwards for this. But I think that's interesting, and I think there might be another sort of 800, 850 practices that can be funded with more intense support for transformation and change.
So I think that's definitely positive, and there is some support of transition funding as well to support this. It talks about equity of access as well and choice, and I think this is partly the part where I mentioned it talks about the care navigation stuff. Maybe I can't.
It does, making it easier to switch GP surgeries and sign up for GP surgeries within the NHS app. I think some practices have already activated that. I think we might have done actually at my surgery.
And again, if people want more information about that particular side of things, that actually we have an upcoming webinar with certain providers about how they can help automate the registration process for you. So definitely, again, sign up to that and things. The final thing it talks about then is about this communicating with the public. It talks about obviously that information that you need to share this and stuff with your patients. And absolutely, communication is a really important thing, but that's through practice websites, absolutely should be the front door for most practices, whether that's through social media platforms, whether that's in waiting room platforms, and how does that information present to those patients when they walk into your door? I know we talked about some feedback mechanisms in our previous stream last week, didn't we? How that can be really used in terms of communicating information with your patients and stuff, and understanding care, and also the resources they have access to. So I know for my network, we created some videos about helping to explain how the healthcare system works for patients, not only in English, but also the other languages like Polish, Kurdish, and that kind of stuff, because actually that's really effective information that can help patients understand navigating the NHS, which is complex at times, let's be honest. So, information delivery, communication, definitely part of it.
Yeah, so they commit to a national campaign to educate the public about the use of primary care with 3 main components. So digital access. So this will be about encouraging NHS app and helping people to have confidence to use that. Explanation about the composition of the wider practice team. So it's not just a GP and a nurse. There are other members of the team, pharmacists, prescribers, health and wellbeing coaches, physicians associates. All sorts of different people. And then the wider care available. So actually there are walk-in centres, there's 111, there are other ways, and how to access those effectively and what they are properly for. Community pharmacy, of course, will be included.
You asked me earlier, Andy, this is one of the things I've been asking for years, that general practice, NHS England, government needed to do and stuff. My only concern about this is that they've delegated this to the ICSs, and there's no real support in terms of financial funding and stuff. And so you are going to have significant potential variation in terms of how this works. There's something about having an NHS branded from the NHS communication tool, because it comes with the authority and stuff.
Yeah, I'd read this as commits to a national campaign. That must mean national, right? Not ICS.
It then talks about in discussion with the ICSs in the detail. Like I said, it says national. What does national mean? Does that just mean they're going to
campaign will also
play with the NHS UK
communication toolkits for ITBs to develop their own local messages? So I don't know. I'm hoping we'll get both here, Gandhi.
Fingers crossed. We will see.
But we might not. We'll see. So engaging on the future primary care. So this is the last section, and I don't think there's too much in there really. It references back to the fuller stock take. So I think there's a lot to talk about in terms of the future of primary care. It references back to the fuller stock take and the suggestions that makes around separating acute demand and anticipated care of long-term conditions, and providing continuity where that it adds value. The bits that it also references are talking about, I'm just trying to find it, but discussions about changing of the contracts that we work in general practice, and it does highlight that the 5-year agreed GMS PMS contract settlement ends in March next year, and there'll be new contracting for that, and that they want to engage and discuss what a new contracting model for primary care looks like. And it also, in the same section, very close, talks about the end of the primary care network, DES, which actually happens around the same time scale. So there's an interesting opportunity for the government to suggest another solution that combines those two funding streams in some way, or changes what is separated out into those different funding streams. So I just think we need to look out for how that turns out, really. And there may be some amalgamation of the funding. I'm not quite sure, but there's an opportunity with them both running out at the same date. So I thought that was interesting.
And it also includes the future of QOF, which I know many people have raised the question of how effective is QOF in its current format, and should it be repurposed into something different and stuff, but also what could that different thing be? The final thing it talks about is community pharmacy engagement. And obviously there's a clear focus on community pharmacy being part of this change in terms of access.
Can I just highlight one? I was going to just say there's one sentence just for those wondering about the fate of the partnership model and, and tracking the tone in these different documents. That we will explore alternative approaches that can work alongside the partnership model and explore additional opportunities to better align clinical and financial responsibilities in primary care. So not in the dustbin yet, the partnership.
Yeah.
And then community pharmacy, important part of delivering the plan. which
effectively says they're going to talk
is a
to
short
you.
section. We've talked about that previously, and the document has handled that previously. So we got there, Gandhi, and a number of people appear to have stayed with us for the whole time. So I guess we can take some responses that have been coming through from people in the audience out there, and maybe we have some reactions ourselves, really. Although a lot of the funding is recycled, and a lot of the announcements are recycled in many ways.
So how about we go with some of the Q's and A's first? Let's get through a few of those. I'm going to bring them on. So we've got Christina. The NHS app dashboard is useful, up-to-date information to enable practices to benchmark and potentially share best practice by contracting local practices who have a higher percentage, highly recommended. And interestingly, there's a couple of comments come through from other people. So James Howe, as a patient in Surrey, my NHS app shows me nothing, prospective access only from memory. And he was the same person who asked the question about will apps die. AM Cook says other apps are already sitting behind. I've just tried my NHS app to send a message and it quotes that the provider we use as the practice. And it mentions by Christina that it cannot send messages to your healthcare services. I think it's for service messages only. I think there's something about the fact that, admin requests only being processed at particular times. Why are we highlighting these? Well, I think it's important to recognize there's still going to be local variation in terms of how practices use online tools and that kind of stuff, and the level that they have. Many practices are talking about switching off these online tools in the out of hours aspects because of the risk and the capacity and the demand that it causes, the volume of stuff that comes through and things. So there is going to be a difference in experience. It can be frustrating. I know my own practice doesn't allow me to send messages to them, which potentially could be, a different way to access healthcare and stuff, but there is going to be variation in that sense and things. I think we're coming to questions. So we've got some interesting ones. Where was it gone? James Howe, what do you think about receptionist triaging online requests? The GPs doing be quicker and safer? It's an interesting question, isn't it, Andy? Because actually, I don't think receptionist triage, or they shouldn't be ideally. They signpost, which is a different definition.
Yeah, I mean, I'm never comfortable with reception triaging because I think that implies decision making, whereas signposting would be following very, very clear protocols and providing information to the patient so that they can sort of make a decision essentially. So interesting about what we're thinking about doing at our practice and our experience of sort of online requests. Really, I think what you find is a very high volume of online requests are things that you don't really want your GP doing anyway. They're sort of I'd like to have depending on how it's streamed, but they're about repeat prescriptions, they're questions to chase up appointments, all sorts of things, which actually, in the past, I've had patients book an appointment, sit in front of me, and then just say, oh, can you chase up this appointment, at the hospital that I'm waiting for? Or I'd like to request my repeat prescription. That used to happen. So, with all those things coming through your electronic consulting workflow, actually, I think it makes sense to maybe have, specially trained admin people as the first port of call, because a lot of those people can be sent off to other departments. That admin person may be trained sufficiently to deal with that query. There may not be clinical uncertainty there, which I think is where you need your medically trained staff. So I don't like receptionists triaging online requests, but in terms of being the first people that look at and redirect online requests, I think that's entirely appropriate, I think.
Yeah, absolutely. And I agree with that premise. Yeah, clinical triage, no. However, signposting, navigation of the system, yes. I think that's the key thing. So other questions we had. So there's one about video comment, actually. A&E SAS doctors do work independently, not sure about other departments. So this may be in response to our comments about the
not an area we've got deep knowledge in. So if we've offended any SAS doctors, apologies.
Yes. But I guess there's also the difference of when you're working even in an A&E as an independent clinician, the patient would have had contact with a variety of other people before they've potentially even got to you as an A&E doctor. So they may have obviously seen the reception team in terms of taking information and categorizing the reason they're there. And potentially would have seen a nurse or another member of the healthcare support team evaluating things, taking OBS, that kind of stuff. You may go in and do the actual history taking and management, but then other things may have happened, like blood's being taken by other members of staff, checking in on them. You've got triangulation of care that occurs in those situations. In general practice, it's very conceivable. The patient walks into a practice, signs in through electronic screen, goes to your appointment room and leaves, and that's it. There's no contact with anybody else. There's no triangulation of care. There's no other perspectives, and the management is completely your responsibility or the practice's responsibility. And there's that element of independence that's different to working independently in hospital.
Yes, but any department's maybe the most similar place to primary care in terms of its undifferentiated, unsorted, case mix that's just coming in the door, and often you've got more junior people signing off on a discharge, I guess. But good point.
Facebook user unknown, recruiting retired GPs versus improving conditions for current GPs to reduce the brain drain. Yeah, well, we've mentioned that a few times, haven't we, Andy? And then comments about the retired GPs, the cavalry, come to save that same hellhole that we're already in, then we'll rapidly depart. Joke, right, NHSE. Fairly strong comment there, I think, but potentially reflecting some of the thoughts many people have in terms of some of the support we currently have.
If people want to leave, why are they going to come back? It's just
exactly. Christina, a couple of comments we have from her, but ICB discretionary financing is worrying. I think it's an interesting perspective. So this probably relates to the capacity impact funding reports that many networks are currently submitting. It's that £1.30 per patient that is the 30% that we mentioned earlier that networks will potentially get next year, depending on how they do with their plans and that kind of stuff. An ICB decision is an interesting perspective. At least it's not central in some ways, but then also how do you evaluate it? I think that it's going to be an interesting time to see whether practices and networks will be receiving that funding. Video mentioning, will PCNs continue 24-25 onwards? So we know that the PCN contract finishes in March 24. We don't know what this means afterwards, aside from the ARS funding is due to be continued over and rolled over to the ICBs. Everything else is still up for grabs because it's currently being negotiated. We will hopefully find out in due course, depending on when they deign to tell us.
Yeah, but that does mean that everything from IIF to clinical director funding to the £1.50 core funding and the £1.76 that goes direct to practices to support network activity, all of that goes, which is quite a large amount of money. And all of that's happening at the same time as the core contract and the PCN DES contract is being looked at. So there's big potential to reshuffle a lot of this funding, I think, and no guarantee that a large portion of that funding that isn't the R's funding would continue at all. So interesting time.
Andy, I'm going to suggest, because we have gone a little bit over time, I'm going to do this in a slightly different way than we planned, okay? So one thing that Andy doesn't know that I've done whilst we've been doing this is I've asked the question to our viewers what they thought, which action do you think will make the most impact on GP access? So we've had some of our viewers polling on this. I asked about the 4 different areas: cutting bureaucracy, empowering patients, implementing modern general practice access, and building capacity. Okay, so those are the 4 key areas in this document that we've just outlined. And through this, people have been responding. In terms of the responses, so 17% felt that building capacity will have the most impact. 17% thought implementing modern general practice access will have the most impact. 29% thought that empowering patients will have the most impact, but it was cutting bureaucracy at 35% that they felt would have the most impact in terms of the delivery of general practice moving forward. So really interesting perspective there from obviously our viewers, and our viewers are potentially selected cohort people. I think what would be really nice to know right now, though, is our reflections on this particular stuff. So Andy, I'm going to suggest in a minute, summarize how you think this is going to go, and I'll then do the same.
Okay, I think there's not a lot of new stuff actually in this document, is the first thing to say. There's a mixture of some quite positive, logical things and some worrying things. The most worrying thing for me is towards the beginning of the document and the focus or obsession on the 8 a.m. Rush and doing something about that in short order, because I do think the 8 a.m. rush is in some way a symptom of a system that is failing because it is under resourced, it's been underfunded for a long period of time, it doesn't have the right workforce in place. We all know these things, and I just worry that will fail, or we will solve the 8 a.m. rush but create all sorts of problems elsewhere within the system that we may not even understand where they will be at the moment. So actually, whilst when you're getting into the nitty gritty of some of the things towards the end of the document, you can start to think actually a lot of this is sensible. Like the initial kind of premise, of the document, I think is quite worrying. I think it's quite political. in its nature. So I am actually a little bit troubled by this. I think also it has the flavour of Department of Health seeking quite granular control how general practice performs in every general practice up and down the country in a way that it hasn't before. I think previously we've had a bit more of a let 1,000 flowers bloom. If telling people to call back the next day, works very well, and there's very high level of satisfaction with the general practice in a certain area. That they've been allowed to do that. In other places where people are less satisfied with that and it creates friction with the population, people have adopted other ways of meeting patient demand, and that's sort of previously been the way things have worked up until now. We've let individual general practices or groups of general practices cater to their local demand, in a way that happens organically in those areas. And this is very, very directive, very, very top down and political, and that worries me. So that's my conclusion, Gandhi.
Fair enough. I guess looking at the plan from my perspective, there is some stuff in there that seems relatively positive, and I think the headlines have obviously focused on particular things like the telephony access, which helps in some ways, doesn't fix general practice access. It talks about the community pharmacy schemes. Well, locally, we've had access to a pharmacy first scheme that was decommissioned and now potentially going to be recommissioned at a stripped down version of it. And obviously that's a problem for patients in terms of their access and the communication side of it and things. I think there is some stuff in there that's quite nice about patient access in terms of information, taking more responsibility of their care with the right information, and also around the huge things around potentially improving bureaucracy and streamlining of care, particularly with that interface of secondary care, which I think will have a real impact if it's done properly. I think a lot of people got focused on the headlines. I think the plans themselves are okay. One thing it doesn't deal with, though, in any way, shape, or form effectively is the fact there just isn't the capacity in primary care currently. And that information communication plan that they've got very much still seems like the last thought thing out that they're going to do.
And unfunded. I didn't see any funding.
Yeah, no funding attached to it. So therefore, does it actually going to happen because there's no funding with it? So actually, how effective is that going to be? And I think, again, this still leads on to another document being a direction in terms of the workforce plan, which has probably got more bearing in terms of what we need to know about how to change some of this, because actually it's the workforce that we are lacking in general practice, which is why there is such a capacity issue in general practice. There is not an access problem. There is a capacity problem in general practice. That's my view.
That's a good place to draw it to a close, I guess, Gandhi. It's great that people have stuck with us, and actually I think more people are watching now than they were in the middle, which is
amazing. And thank you to all of our EGP listeners. So if you have enjoyed this, absolutely leave us a like, leave us a comment, something in that to tell us what you thought about this episode, because this is actually our longest episode ever. We appreciate that you've stuck with us throughout this whole thing, and we hope you've enjoyed it. Obviously, we've got more resources to come. We mentioned about the fact that we've got that episode on cloud-based telephony coming shortly. We've got that episode about automation of GP registrations coming shortly, and absolutely check out that bureaucracy busting Concord episode that we've done, because it seems like many of you are thinking that the bureaucracy is the key thing that's going to help us in general practice.
And the full stock take episode as well. That's a good one.
Yeah, absolutely. So check out those episodes, because they will give you the information and the resources to go to your ICSs, to go to your ICBs and say, these are the things that we need to look at. And we've mentioned some actions in there for particular practices as well. If you're in those situations, definitely have a look at those. There's a couple of things I've taken for this I'm going to be doing for my practice, and I think there's many other areas of general practice that need to focus on that. As ever, if you want more information, we're always here to provide that. That'll probably be coming up around here as ever, and we're as ever here to continue tech enhance your primary care and learning, and we will catch you in the next episode.